Good morning, everyone.
Hello. Hello.
Hi everybody. Can you hear me?
असं एकदम छान.
आवाज ठीक येतोय की कमी येतोय?
जास्त येतोय सर. हॅलो.
आवाज आ रही है नहीं? मुझे लगा कम आ रही है, तो फिर मैं तो दूसरे लैपटॉप पे मैं कनेक्ट करता हूँ. Is the voice okay? Volume okay? सतीश?
एकदम छान है वॉल्यूम सर. थोड़ा सा वीडियो एडजस्ट करा.
हाँ, वो तो कर लूंगा मैं. वो तो मला बॅकग्राऊंडला माझं हे असल्यामुळे आय विल हॅव टू डू इट. दॅट आय विल डू इट. पण आवाज येतोय का बरोबर?
छान आहे सर.
तसे मी याच्यासाठी मी दुसऱ्या याच्यानी कनेक्ट होणार आहे. कारण याच्यात व्हॉइस क्वालिटी बरोबर नाही आहे. इनॉग्रेशन के बाद में मैं चेंज कर दूंगा.
पण आता सध्याला व्यवस्थित आहे सर, ऑडिओ व्हिडिओ दोन्ही.
हाँ,
Very good morning to everyone.
हरी सर नमस्कार.
हाय हरी.
Namaskar, sir. Hello.
डॉक्टर हरी मंगतानी नमस्कार.
Yes, yes, sir.
डॉक्टर नितिन राउत इज देयर. देयर आर सो मेनी पीपल.
Yes,
सबको
yes, I can
गुड
see
मॉर्निंग.
you.
गुड मॉर्निंग टू एवरीवन.
Good morning to everyone.
डॉक्टर रेणू बोराळकर इज विथ अस. येस. Women's chairman.
Hello, namaskar everyone. Thank you for inviting.
Good morning everybody again, Dr. Renu.
Good morning, sir. Good morning, Satish ji.
तुम्हाला पहिलेच नमस्कार केला नाही.
Very nice concept. It is a very nice concept you are taken for all the women over there, and a unique CME. I have never heard of it like this.
And if you look at the faces now, so we have all good faces. Including Nishant Kotwal sir. He's the leader.
Okay, congratulations to all the team.
सतीश को बढ़ा चढ़ाने की बात करने की आदत है, याद रखना।
सर को देखे तो ऊपर पता ही नहीं चलती, वैसी
किसी
वैसी
की भी ज्यादा तारीफ की तो वो सच नहीं मानना है।
सर आज कन्वीनर है, वो कुछ भी बोल सकते हैं, है ना सर?
And he is a great player. No
The
doubt.
mic is in his hand, so he can mute any one of us also if we want.
But Satish never misuses. I have seen.
नहीं, I am just joking, sir. Nothing apart.
नहीं मैम, मेरे हाथ में कुछ लाइक नहीं। होस्ट इज मिस्टर प्रकाश जी, इवेंट मैनेजर। मेरे हाथ में कुछ भी नहीं है। आई एम नॉट गोइंग टू स्पीक अ सिंगल वर्ड अपार्ट फ्रॉम इंट्रोड्यूसिंग द इनिशियल पर्सन, बस।
अच्छा,
अपनी जरूरत ही नहीं बोलने की। हम तो निखिल सर से सुनते हैं, लोग बोलेंगे अपने लिए, अपने क्या बोलना है सर? बराबर है।
बराबर है।
सुनने के लिए भी कोई चाहिए ना।
We welcome Dr. Naresh Tade, President IIT Amravati.
गुड मॉर्निंग सर.
गुड मॉर्निंग नरेश. नागपूरला अमरावतीला?
काय म्हणता सर?
नागपूरला आहे.
हॅलो.
He is traveling, I think so. I saw him in the car.
मैडम की बहुत बारीक नजर रहती है. We are Rishikesh Ghator with us. The person who will be doing all this thing. मैम जो आप बोल रहे थे ना?
Hi, sir. Good morning, sir, and good morning to all the delegates.
सर जी सत श्री अकाल।
सभी को नमस्कार।
पहले बोला सर।
खुश रहो, मजे करो।
बस
ये टेबल पे सब क्या वर्चुअल फूल आए हैं क्या आपके पास?
क्या
ये टेबल पे सर के सतीश भैया के वर्चुअल फूल आए क्या?
नहीं सर, रियल के बिल्कुल
रियल के हैं सर?
हाँ, 1 महीने से ऐसी कैसी है।
रियल लाइक यू।
सर वो है ना, क्या निष्कल कोतवाल सर ऑब्जेक्शन लेते थे किसी तारीफ हुई तो। कोतवाल सर बोलते कि ज्यादा हुई तो फिर सच्ची नहीं रहती बोले। अब मैं तारीफ लायक लोग हैं तो उनकी तारीफ करना चाहिए।
सही बात है।
तो तेजा सर के मन में कुछ तो भी आ रहा है सर, बोल दो।
नहीं, मैं सोच रहा हूँ कुछ।
सर और बधाई हो। अभी आज आप फोन पे वीडियो पे मिले हैं, बधाई हो फॉर दी ओरेशन इन योर नेम।
थैंक यू सर।
Namaskar, sir, to Teja, sir. I am Dr. Renu Goralkar. I am a chairperson of this Women's Committee of Maharashtra IAP, sir.
Thank you so much, so kind.
And congratulations, sir.
आपसे मिलने का वर्चुअली सौभाग्य प्राप्त हुआ मुझे।
सर आप दिल्ली में आने वाले होंगे तो मैं जरूर मिलूंगी सर आपको।
नहीं, मैं नहीं आ रहा मैडम।
ओके,
अभी डर लग रहा है मुझे। अभी कोविड फोबिया जा नहीं रहा है।
Okay, sir, no problem.
Good
आपके
morning,
रोज
good morning, Tuteja. Good morning.
जी सर, उदय भैया।
सत श्री अकाल,
सूरज तो अभी
वाहेगुरु
सूरज-
सर, वाहेगुरु।
सब लोग अंधेरे के बाद सूरज तो
morning.
अभी निकला है, उदय हुआ
गुड
है।
मॉर्निंग डॉक्टर उदय बोधनकर।
कोतवाल सर, प्रणाम प्रणाम। अरे
सर
थोड़ा
आपने सुना नहीं?
क्या
उदय भैया
बोला?
आपने सुना नहीं?
हाँ सर सर सॉरी।
मैंने बोला कि अभी तक अंधेरा था, आपके आने से उदय हुआ है, सूरज निकला है।
सर वाहेगुरु, सत श्री अकाल सर, प्रणाम।
वाहेगुरु, वाहेगुरु।
रेणु प्रणाम।
सर नमस्कार, खूप खूप प्रणाम.
You are seen on the globe, Renu, and I am seen on the Goa beach, and Kotwal sir is in the house, and Satish is seen in the house. So how is Aurangabad?
Sir, it's very nice, pleasant.
No corona. Indore?
No corona now. Yeah.
थोड़ी जैसा आप आइए, वहाँ आइए। कितना 10:45 बज गया? अरे आई थिंक वी हैव टू स्टार्ट सतीश।
Yes.
सॉरी। 18 people.
Request to everyone to get mute. Now we're going live on YouTube. So in the capacity of convener of the CME, I welcome all the faculty, including the speakers and the chairpersons, the organizers of the CME, and the session charge. So before we start the actual CME at 10 a.m., we have a short inaugural ceremony for which we have a session charge, Dr. Rishikesh Ghator. Dr. Ghator is a well-known pediatrician at Amravati, dealing with the developmental pediatrics. Last time we have seen him as a faculty. He does his work at Trias Child Development Autism Intervention Amravati, has done his fellowship at Learning Disability and Neurodevelopment Pediatrics. He has been a certified trainer on a person with special education done at Chennai. So I invite Dr. Rishi Ghator sir for further proceedings.
Thank you, sir. Thank you, Satish Agrawal, sir, for this kind introduction. And on behalf of IIP Amravati, I welcome you all for the today's CME on women's care. At the start of the CME, I would like to invite our esteemed guest, and I request them to say a few words. And at the start, I would like to invite Dr. Renu Boradkar, madam, who is a senior pediatrician and who is in charge of the Women's Wing Committee of Maharashtra IIP. So, Renu Boradkar, madam, please say some few words on this occasion of organizing the CME on women's care.
Yeah, namaskar. Good morning, everyone. It's a very great honor to share a platform with our Mahaguru, Dr. Bodhankar sir, and great teachers like Dr. Tuteja sir, Dr. Satish Tiwari sir, Dr. Swati Ghate ma'am, and Dr. Kotwal sir. I congratulate Team IIP Amravati President, Secretary, and Convener Dr. Satish Agrawal ji, and Patron Dr. Pandrikar sir, and also Dr. Kotwal sir for this beautiful, unique CME on women care. I want to share a few lines for all the beautiful women out there by Mother Teresa. If your eyes are positive, you will love the world. But if your tongue is positive, the world will love you. So congratulations, Team Amravati, and all the empowered and gorgeous ladies of Maharashtra IIP. Happy learning to all of you, and thank you for inviting me. Happy learning to all of you. Thank you.
Thanks, ma'am. And now I would like to invite Dr. Uday Bodhankar Sam, Uday Budharkar sir from Nagpur, who is a well-known pediatrician and the past president of Central IIP. And I like to, hello, am I audible?
Yeah. Hello.
Yes.
Good morning to all of you. I am grateful to IIP Amravati branch for inviting me to speak few words during this. And the CME which has been held on women care is really appropriate. President IIP Amravati Dr. Thaide, Secretary Rajput, convener my friend Dr. Sajid Agrawal, respected my mentor Dr. Tuteja sir, respected Kotwal sir, Dr. Satish Tiwari, Dr. Pandikar, Dr. Swati Ghate, and respected all the dignitaries, of course, Dr. MMC Azura, Dr. Munje Madam, and Renu, of course, Renu Bolal with me. I will not take all the name, but thank you, Satish, and IIP Amravati for inviting me for this platform. I will not go into details because Dr. Renu has already said few words. I just want to highlight in the presence of stalwart like Tuteja and Kotwal and all, a national survey which was held ahead of the International Women's Day underlined ill health among India's women, which is very surprising, with anemia affecting over half of the respondents, while 72%, this is very take-home message, I think today, 72% had vitamin D deficiency, 72. The recent National Health NFHS 5 also showed that 66% of the India's women were anemic, as against 55% were found in NFHS 4. I think alarming. Also, the TSH hormone, which is abnormal, was over more than 25% in this survey. I think very good. So I think shocking thing for women. The survey also highlighted the big Indian dichotomy in health. While half of the population is undernourished, surprise, the other half is obese or overweight. Also, this is the take-home message from this survey. While some of the parameters of maternal mortality are improving in India, we still have a long way to go. India's overall MMR, which was around per 100,000 live birth, which has improved from 130 in 2014 to only 113 in 2018. So I think we have a lot of things to be done, and this is a good thing that IIP Amravati has taken compliment OBEB of Amravati. Last few lines with the permission of the chair convener. The day the child realizes that all adults are imperfect, I think that is the time he becomes an adolescent. And the day he forgives them, I think he becomes an adult. And the day he forgives himself, I think he becomes right. This is in short about adolescent. And just few lines, as Renu said, International Women's Day, almost all of are here. सब पर भारी हो, हाँ मैं नारी हो. Few lines, सब पर भारी हो, हाँ मैं नारी हो. कभी दुर्गा बनकर प्यार देती हो, कभी लक्ष्मी बनकर वर्षा कर जाती हो, कभी सरस्वती बनकर ज्ञान देती हो, तो कभी काली बने दुष्ट को संहार करती हो. सब पर भारी हो, हाँ मैं नारी हूँ. खुद भूखी रहूं, पहले परिवार को खिलाती हूँ. कम में कभी खुशी खुशी जिंदगी संवारती हूँ. तपती धूप में चलते पैरों पर पड़े छालों से भी नहीं हरती हूँ. सब पर भारी हूँ, हाँ मैं नारी. लास्ट लाइन, माता पिता का सहारा हूँ, बुजुर्गों का आशीर्वाद हूँ, पूजन की देवी हूँ, घर आंगन की तुलसी हूँ, चांद पर भी फतेह गाड़ के आती हूँ, मैं देश को भी चलाने का जज्बा रखती हूँ. सब पर भारी हूँ, हाँ मैं नारी हूँ. Thank you.
Thank you. Thank you, Bodhankar sir, for such a great lines. And when Bodhankar sir is here on our platform, we never be deprived of the knowledge and the simplicity of him. So I would also like to invite Dr. Radha Munje Madam, who is the HOD of the tuberculosis department, heading the tuberculosis department at IGMC Nagpur, and who is also the observer of the today's CME. And I would like Radha Munje Madam to say some few words. Radha Munje Madam.
He was there, doesn't look. How does?
क्या होता है ना?
Madam was there,
yeah.
But now I don't see her here on the platform.
Maybe त्यांचा Wi-Fi आहे झाला असेल काही.
Dr. Naresh Tade, President of
Yeah.
Rushesh. Dr. Naresh Tade, sir. President of
Satish, hope I have finished in time.
So it's time to head forward. And at the start of the CME, I would like to invite and our IAP Amravati President, Dr. Naresh Tayade sir.
Continue. Naresh Tayade sir.
Dr. Naresh Tayade sir, who is the geneticist and the director of the Life Care Hospital Amravati, and also the associate professor at the PDMC Amravati. And because of him, all these things are possible. And heading towards Naresh Tayade sir and requesting him to say a few words.
Good morning, everyone. I welcome all the delegate faculty for this CME Women's Care. I congratulate Dr. Satish Agrawal sir for their consecutive third CME on online CME on this platform, with going on for different topics on children's, women, and neonatal health. And today's our topic is on women's care, and for guiding us, there are many stalwarts in this area which are going to tell you about how to care for the women so that our nation's health will be at the best. So I request everyone to enjoy the educational feast and congratulate again Dr. Satish Agrawal sir for conducting this CME. From behalf of IAP Amravati, again I welcome everyone to enjoy this CME. Thank you.
Radha Munde madam is visible. Radha Munde madam, final word.
Dr. Radha Munde madam.
Hello.
Yes, ma'am. You are audible, ma'am.
Am I audible?
Yes, ma'am.
I thank MMC for making me observe and be a part of this wonderful CME, which has been specially organized with the aim of a health betterment for children as well as women. And when I went through the content, it's indeed a great content to have. And I'm sure it would be beneficial for everybody who joins it. It's my proud privilege to share today's screen with stalwarts like Dr. Bodhankar and Dr. Kotwal, and of course the organizing team from Amravati IAP, starting with none other than Dr. Satish Agrawal and Dr. I don't forget the names, Dr. Booth and so on. Thank you for having me, and have a great learning throughout the day. Thank you.
Thank you, ma'am. Thank you, ma'am. Satish Agrawal sir, can we move towards our actual CME part?
Yes.
Can we start the session, sir?
Yes, it's right.
Yes, sir. So we are on the time.
इनॉग्रेशन चालू हो गया, महात्मा सर कब क्या गए? हाँ, मैंने तो तुमको देखा नहीं.
So we are on the time, and we will now start with our actual CME and the sessions. And so, first session, I would like to invite Dr. Murmai Bobre madam, who is a well-known pathologist and the director of the pathology lab at the Parijat Hospital at Amravati, and Dr. Neeta Mundra madam, who is the senior pediatrician from Amravati. And the topics which will be discussed during this session are pubertal problem in girls by Dr. Hari Mangtani ma'am, and the maternal and child health national program by Dr. Nitin Rao sir, and mother as a role model by Dr. Sonali Shilpate ma'am. So requesting Dr. Neeta Mundra madam and Dr. Murmai Bobre madam to start with our first session. Thank you.
Thank you, sir. Am I audible?
Yes,
Hello.
yes, ma'am. Yes, ma'am. You are audible, ma'am.
First of all, a very good morning and warm welcome to everyone in today's CME. Before we start with our session, I, Dr. Mrunmai, on behalf of myself and Dr. Neeta ma'am, would acknowledge the organizers for giving us this opportunity to chair today's CME. I welcome our esteemed speaker, Dr. Hari Mangtani sir, for today's CME. Sir is renowned pediatric endocrinologist practicing in Nagpur. He has done his fellowship in pediatric endocrinology at Alderhead Children's Hospital, Liverpool, England in 2019. and he was awarded by the European Society of Pediatric Endocrinology for the same. He has done ICMRCC in medical genetics and genetic counseling at the Department of Medical Genetics from SGPGI Lucknow in 2018. Puberty is a very important milestone in every young girl's child. Every girl faces many questions like why and how. So I welcome Dr. Hari Mangtani sir, who will throw light on various problems of pubertal girls. Over to you, Dr. Hari Mangtani sir.
So thank you, madam, for your kind introduction. And I would like to thank IAP Amravati for giving me this opportunity and share the dais with stalwarts like Dr. Bodhankar, Dr. Tuteja, and Dr. Kotwal. I would like to thank Dr. Satish Tiwari sir, Dr. Satish Agarwal sir, Dr. Bhoop sir for showering their blessings on me. So I'd like to share my screen, and I would. Now you can, everyone can see the slides.
Yes, we can see.
Yes, sir.
Yeah.
Yes, sir.
So today we are going. This is a wonderful platform actually, and all about women we are talking today. This is a very new kind of an initiative which was taken by IAP Amravati. So what I am going to discuss is puberty issues or puberty problems in girls, and which are less discussed, and because it's a transition, it is not the adult domain also, and falls in the cusp. So pediatricians also, they do not talk much about the pubertal changes, and also the gynecologists and other adult physicians, they also don't talk or about these puberty issues which we see in girls. So what we are going to learn today is normal puberty, and followed by some discussion on precocious puberty and as well as delayed puberty, because these are the two major issues of puberty which we see in girls. So what is normal? Once we understand what is normal, then only we'll be able to make out what is abnormal. So it is the development of secondary sexual characteristics that happens in every female, and the girl converts into a woman. But it should start at a certain age. So it's a natural phenomena, but the most important thing, the certain age. The age is the important factor in here, and the changes which happen should be feminine in girls and masculine in boys. So with this, we can find out what is abnormal, that is precocious puberty. So this appearance of secondary sexual characteristics appearing before the age of 8 years. Now this is a foreign definition, and perhaps in India we should think of 9.5 years as a cutoff. But I don't know. The seniors here should be working on it. And it is delayed puberty. That is no telar, no breast development by the age of 13 years, or if the gap between appearance of breast bud to menarche, that is telar to menarche, is more than 4 years, then it is considered as delayed puberty. Along with this, if there are sexual characteristics developing of the opposite sex, that is virilization which is occurring in a female, so that can be called as abnormal. What is the pubertal physiology? We know that from early childhood to approximately 8-9 years of age, which is also called as the prepubertal age, the hypothalamic pituitary gonadal axis, which is the HPG axis, remains dormant, and it is biochemically characterized by undetectable serum concentrations of gonadotropins, particularly luteinizing hormone as well as FSH, and also there is low estrogen, that is the sex hormones are also low. Now during this phase, from early childhood to the prepubertal phase, the activity of the hypothalamus and pituitary is suppressed by the neuronal restraint pathways. And with the onset of puberty, what happens? There is a pulsatile secretion of gonadotropins which occurs under the influence of hypothalamus. So what happens is the hypothalamus starts secreting GnRH, that is gonadotropin releasing hormone, which stimulates the pituitary gonadotropes to secrete gonadotropins like LH and FSH, and under the influence of which it occurs enlargement and maturation of gonads. So the gonads, they mature, enlarge with this pulsatile secretion, and they start secreting sex hormones. And with the appearance of sex hormones, the secondary sexual characteristics, they start appearing. So a few words about hypothalamic GnRH. It is a primary hormone responsible for the onset, maintenance, and progression of puberty. It is secreted by the hypothalamic neurons, and this is neurosecretory unit is called as GnRH pulse generator. Now, the factors that normally activate or restrain this GnRH pulse generator, they have been not fully characterized. Partially, we have been able to come around few genes which are important. We will be talking on it. So what is the sequence? There is always the puberty development follows a sequence, and the sequence is the breast budding. Telarc is the first sign of puberty in girls, usually which would appear around 10 years. However, it is said that few of them, around less than 10%, they can have pubar first, followed by breast development. So breast development usually is the first sign of puberty. It is followed by appearance of pubic hair, which happens 6 to 12 months later, and the interval to menarche is usually 2.5 years, but it may be longer, up to 4 years also. Now, peak height velocity. So the velocity of height in which the girl gets the highest or gets a pubertal growth spurt, it happens early during the breast stage 2 and 3 and always precedes menarche. So that's why we say when menarche happens, then the height potential, remaining height potential is very less. The girl has already achieved more than 95% of her final height. So all this pubertal sequence development, they are closely correlated with the osseous maturation. These are the Tanner staging. I'm not going to go into details of this, but one can keep placard of this and can, before examining, if the girl is shy and not giving the consent for examination, we can ask the mother that which stage she is in. So mother will clearly say which stage of Tanner the girl is in. So coming to the first issue, that is precocious puberty in girls. Now this picture tells most of the things. We see a girl, but the shadow is of a woman. So this is the brain or psyche of a girl who has developed, who has got hormones, and she is confused, as well as the others also get confused looking at the child, because they feel that the child, this girl is around 16 or 17 years of age, or it must be 13, 14, while the child is only 7 years, 6 years. So this is what precocious puberty leads to. So the onset of secondary sexual characteristics before 8 years is considered precocious. However, premature adrenarche before the age of 8 years also is considered precocious. If menses happens before the age of 9.5 years, they are also considered as precocious. Now, when we see precocious puberty, it has two major groups. Their classification in central precocious puberty. Now, this is also called as gonadotropin dependent puberty or true precocious puberty. And the other one is peripheral precocious puberty, that is gonadotropin independent or precocious pseudopuberty. So we'll see both of this. Now, central precocious puberty, it happens because of premature activation of the HPG axis. So it is like a normal thing happening only. The only abnormality in this kind of puberty is the timing. So it is always isosexual, because I said it is normal. It has to be the same, the hormones comes of the same sex, that is the gonadal activation in girls, that is ovaries. So cause, most of the time the cause cannot be found out, but there are organic brain lesions like hypothalamic hematoma, brain tumors, hydrocephalus, or head trauma, which can cause this kind of a picture. And if we do not find a cause for it, then it is considered as an idiopathic central precocious puberty. A few words about hypothyroidism, if it is prolonged and untreated, can lead to partial form of central precocious puberty, also known as von Wegg-Lundbach syndrome. We are not going to go in details of it, but coming to peripheral precocious puberty, these are the secondary sex characters will appear without activation of normal HPG axis. So the sex characteristics, there is no activation of hypothalamus or pituitary gonadotropes. It is direct activation of the gonads. So it is the sex characteristic can be isosexual if it is because of estrogen, or it could be heterosexual, that is of opposite sex, that is masculinization under the influence of androgen. We'll see the causes: isosexual or feminizing condition. The most common causes are McCune-Albright syndrome and autonomous ovarian cyst. McCune-Albright syndrome is a triad characterized by bone dysplasia, precocious puberty mostly, and large cafe au lait spots we see, and multiple endocrine issues in such patients. There can be ovarian tumors which secrete excessive estrogen, and it could be a feminizing endocrine tumor which is very rare in variety. It can also happen because of exposure of exogenous estrogen. So some mother is using some estrogen cream, if the child gets exposed to it, she might develop signs of puberty. Heterosexual, the most common cause is congenital adrenal hyperplasia, and it could be adrenal tumors or muscularizing ovarian tumors. I'll show you this case. There's a 4-year-old girl who presented with breast developments in 6 months and vaginal discharge. She has got increased appetite and she is tallest in class. There were no neurological complaints or capsular spots. There were no bony deformity or fracture or no medication exposure in this child. On examination, she had breast stage 3 bilaterally, vaginal mucosa was pink, and height was 109 centimeter, that is 97 percentile. On investigation, the LH was detectable in this child. The bone age was advanced to 8.6 years, and FSH also was seen 2.4. The estrogen was also detectable, and the stimulated LH levels were significantly higher. So when we did a USG, it suggested a uterine dimension increased with the endometrial thickness of 4 mm. The MRI was normal. So a diagnosis here we can see that the child has got precocious puberty which is happening early, and it is because of activation of LH, detectable LH and stimulated LH also high. So this is central precocious puberty, and the MRI was normal. So we could not locate the cause of this, and that's why it is idiopathic central precocious puberty. So every word has to be defined like that. What about the treatment? Now, why we are going to treat such kids? Important is, I told you that there is a pubertal growth spurt happens before menarche. So the girl looks taller initially when she enters puberty. But what happens with the appearance of menarche? The bone age get advanced under the influence of estrogen, and the final height is lost. So initially the girl looks taller, but she stops growing early, while the remaining girls who are smaller, they gradually come up. So there is a loss of height potential, and there are psychosocial issues. Just imagine a 9-year-old girl in 4th standard or 3rd standard managing menses. What kind of a psychosocial stress or what kind of psychosocial stress the parents must be going through. So these are the 2 reasons for which we treat such kids. How do we treat? GNH analog report preparation, monthly or 3-monthly injections are available. And what does these injections do? There happens a regression of secondary sexual characteristics. There is slowing of the height gain, slowing of the bone age advancement. So the speed at which the bone age is advancing, it also comes down, and finally improving the adult height. So I recommend that if there is a loss in height potential, or a girl who is suffering from psychosocial issues and has got precocious puberty, should get treatment. Now coming to the second issue of delayed puberty also called as hypogonadism, and it is defined as absence of breast development by 13 years of age, or thelar to menarche age. That is what we discussed, that is more than 4 years gap. Some consider primary amenorrhea also as a limb of delayed puberty. So no menarche by the age of 14 years if the secondary sexual characteristics are absent, and if they are present, then no menarche by the age of 16 years is defined as primary amenorrhea. Now coming to hypogonadism, if we classify, it could be into again dichotomized classification: hypergonadotropic hypogonadism and hypogonadotropic hypogonadism, which is called as primary and secondary. So coming to hypogonadotropic hypogonadism, as the name suggests, the gonadotropin levels here are detectable and normal or higher, while the estrogen, the gonads are not secreting any the sex steroids. So it can happen because of altered secretion of gonadotropin, and the cyclicity of this gonadotropin gets affected. It could be because of receptor dysfunction also, or it could be directly related to ovarian pathology or dysfunction. Now the causes most common is Turner syndrome, where we have got streak gonads, streak ovaries not secreting any kind of sex hormones, and these girls remain prepubertal for a long period of time. Gonadal dysgenesis also could present as hypergonadotropic hypogonadism or autoimmune ovarian failure. Now trauma or infiltration of the ovary, or if the child or the girl has received chemotherapy or radiotherapy, they can damage these gonads and can lead to hypergonadotropic hypogonadism. Now, history will be consistent with the cause, that is, there will be history of chemotherapy, radiotherapy, or there could be history of surgery or torsion. Examination should include Tanner staging, skeletal stigmas of Turner syndrome, and other autoimmune condition if it is present, which increases the chances of primary ovarian failure or autoimmune ovarian failure. Biochemically, they are characterized by high gonadotropin levels or detectable levels of LH and FSH, but very low estradiol levels. AMH and even they may suggest poor gonadal function or poor ovarian reserve. But usually LH, FSH and estradiol level points towards most of the diagnosis. Now, how do we treat such kids? We have to induce and maintain puberty. That is one of the aim of treatment. The other aim is developing the uterus for a possible fertility. So the uterus dimension should increase to accommodate the fetus in the later life, and finally to improve the final adult so estrogen therapy, we have to start with a very low dose of estrogen, perhaps 1/4 to 1/8 of an adult dose. Gradually increase it every 6 monthly, step by step, to come to a adult dose of by 2 years. And one is supposed to add progesterone if there is a breakthrough bleeding, or there is 2 to 3 years of unopposed estradiol therapy to prevent endometrial hyperplasia. Now, later date, we can have IVF option with donor ovum for fertility. So fertility also can be actually offered with, but we want a good uterine environment, which happens with a gradual introduction of estrogen at a right time of age. So pubertal induction and maintenance are very important aspect of therapy. Now, hypogonadotrophic hypogonadism, it is a very confusing topic, very difficult to actually pinpoint a diagnosis, and I think endocrinologists who are listening, they will agree with me that it is the most difficult thing to reach to a diagnosis. It is because of decreased production of GnRH from the hypothalamus. So hypothalamus could be damaged, it could be only a functional thing which is not seen on MRI. But this hypothalamus is not secreting GnRH, and thus there is no pituitary stimulation of gonadotropes, leading to low gonadotropin levels, and that's why the ovarian function is reduced or absent. So it is not only yes or no, it is a spectrum disorder. It may be reduced, less reduced, more reduced, profound. So it can present as any clinical picture that will come to it, but it can be congenital, that is isolated, or associated with other pituitary hormone deficiency, also a part of multiple pituitary hormone deficiency, or it could be syndromic. If we see isolated congenital hypogonadotrophic hypogonadism, it could be anosmic or hyposmic, also called as Kalman syndrome, or with a normal smell. So these are the candidate genes which are responsible for development of such isolated CH. Now, acquired causes, it could be tumors in the hypothalamic pituitary area, prolactinomas, or infiltrative disorder or CNS trauma to the hypothalamic pituitary region. It could be hypothalamic dysfunction, a chronic underweight child, or a chronic underlying condition which is untreated, like sickle cell or celiac disease. There could be eating disorder or excessive physical activity, particularly seen in gymnasts and ballet dancers. So these all can present as hypogonadotrophic hypogonadism. A few words about constitutional delay in growth and puberty. Though it is a kind of a hypogonadotrophic hypogonadism, here everything is normal. Only thing, the tempo of the onset is
sorry to interrupt, sir. Only 2 minutes remaining, sir.
Yeah, only 2 slides, 3 slides.
Okay, sir. Okay.
Yeah, so constitutional delay in growth and puberty. So it's a normal variant. So it has variable presentation from complete, partial to mild, and history should include CNS insult, anosmia, hyposmia, or TANUS staging with syndromic features. We need to do a serum estradiol level with a low to undetectable, and gonadotropin level which may be low. Other special tests are add no diagnostic information. One might do a genetic test, but important is to rule out hyperprolactinoma. So treatment, coming to it, estrogen replacement for puberty induction and maintenance, as we saw in hypogonadism, and progesterone for getting regular menses. Here the fertility option can be given as versatile GnRH or injection of and FSH, that is HCG and FSH can be given for fertility. So there the fertility was donor-owned and IVF. Here the fertility, because the ovarian function is preserved, we can try with pulsatile GnRH, and many of them they conceive. Other treatment is based on specific diagnostic, like chronic disorder has to be treated, lifestyle changes are to be incorporated with, and growth hormone in cases of Turner syndrome. So with this, I would like to conclude my talk. I made it for 20 minutes only, so I knew that I'm going to finish. So thank you very much for your patient listening. And if there are any questions, I would happy to answer. I have stopped sharing my screen and I'm available to answer your questions. Thank you.
Thank you, sir. Thank you very much for sharing your valuable knowledge with us. Now I welcome Dr. Nitin Rao sir for next lecture. Dr. Nitin Rao sir on the topic of maternal and child health national program. He is consultant pediatrician and neonatologist in Amravati. He did MBBS from Dr. PDMMC Amravati and DCH from government SSMC Reva. He was ex-registrar in Rainbow Children Hospital, Hyderabad, and he is currently practicing as pediatrician and in charge of Nutritional Rehabilitation Center, Government Hospital, Amravati. So now I welcome Dr. Nitin Rao, sir.
Thank you, madam, for this introduction. Am I audible to everyone?
Yes, sir. You are audible.
Okay. Very good morning to all my respected seniors, especially Satish Agrawal sir, Jayant Pandrikar sir from IIP Amravati family, and all stalwarts and respected seniors from IIP National family. Today, I will be sharing my presentations regarding the national health programs for women and child, especially with emphasis on the national health programs that has been run for the women's health in India. Prakash ji, can you share my presentation?
Yes, sir.
Next.
Dr. Nitin, please unmute. Unmute yourself. Dr. Nitin.
Okay. Am I audible?
Yes.
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 Next slide, please. Okay. Yes. So the major milestones for programs for the women health come from 1992 when the initial program CSSM, that is Safe Survival and Safe Motherhood program, was launched. Then the transformation done for reproductive child health stage 1. 1997 it was modified to RCS2 in 2005, and from 2005 all it has been heading by the NRHM, that is the National Rural Health Mission, and even the NUHM, that is National Urban Health Mission for the urban category. 2013 we had that RMNCH strategy, that is reproductive maternal health, newborn and child strategy, and for 2014 there is India Newborn Action Plan also. Next. So goals of these programs were to basically meant for to reduce the maternal mortality to 1 in 1,000, to reduce the infant mortality to 25 by 1,000, and the prevention of reduction of anemia in age of 15 to 19 years, especially in the adolescent girls, to up to 28%, and prevention and reduction of mortality and morbidity from communicable and non-communicable disease and injuries. Next. So these were the initiative taken under the NHM. For first was the promotion of institutional deliveries through Janani Suraksha Yojana. By that only we can prevent the maternal mortality. Capacity building was done for health providers in basic and comprehensive obstetric care, and operation of subcenter, PSC, CSC, and district hospitals for providing 24/7 services for this pregnant woman. And also there was main web-based tracking of pregnant women to ensure antenatal, intranatal, postnatal care. Next. And recent new initiative added to these programs were the Rashtriya Bal Swasthya Karyakram, that is RBSK, then Rashtriya Kishore Swasthya Karyakram, and then weekly iron and folic acid supplementation program. These are the additional programs. Next. So definitely ANC, antenatal, intranatal, and postnatal care, including iron and folic acid supplementation to pregnant and lactating mother, it covers health and nutrition education. That is most important thing, to promote dietary diversification and to include iron and folic rich food. And Janani Suraksha Shishu Karyakram to provide the absolutely free services for delivery, including cesarean sections, lab facilities, food transport from home to institution and drop back home. So 184 high priority districts have been priorities under this RMCS strategy. Next. And again, the children for children, the program where universal immunization program, mother and child tracking system, and Bal Swasthya Karyakram. Next. And various, apart from our government, various associations like WHO, UNICEF, DANIDA, SIDA, NORAD, USAID, all these are helping to run these programs. And so many NGOs, they are working all over the state or all over the country. Like in Amravati district, we have that Plan India, Nutrition India, and Reach Each Child. These associations, NGOs, they are really helping to run these health programs for women smoothly. Next. And all this is coming under NRHM from 2005. Initially, it was launched in 2005, extended up to 2012, then extended up to 2017. Now it has been extended up to 2022. So almost all these programs, they have been covered by NRHM now. Next. So these are the goals of NRHM that we discussed to reduce in the IMR and MMR regarding the women's health. Next. Especially with the help of ASHA workers and all that, we are trying to achieve these goals. And other initiative that were taken for women health, as we discussed, is Janani Suraksha Yojana. We have known Janani Shishu Suraksha Karyakram. Most important was the National Mobile Medical Unit that will be discussed in later. That is helpful to provide the expert gynecological obstetricians and pediatricians help for the ladies and children. They are residing in very remote areas. Next. And NUHM, as we tell that even in the urban regions also, there are so many ladies, they are devoid of the proper care. So all these programs are run in the urban areas by the NUHM. What we call this is National Urban Health Mission. Next. Then coming to the RCH in a brief. Next. So basically, we have to know the definition in the second, that people have ability to reproduce and regulate their fertility. Women are able to go through pregnancy and their birth safely. That is most important. The outcome of pregnancy is successful in terms of maternal and infant survival and well-being, and couples are able to have sexual relations free of fear of pregnancy and of contracting disease. That was the main definitions for reproductive and child health. And the initiatives were taken for this, like family planning, clean approach to healthcare, child survival and safe motherhood component, and prevention and management of RT and STD. That comes under this RCH phase 1. Next. Main highlights, as we discuss this reproductive and child health, and the program is envisaged to upgradation of the level of facilities for providing various interventions and quality of care. The first referral units being set up at sub-district level to provide comprehensive emergency obstetric and newborn care, and if required, they can refer to the higher centers. So this hierarchy was developed in RCH programs. Next. Facilities definitely MTP, IOD insertion at PHC levels, and special facilities for STD and RT are available all districts hospitals. The program set at improving the outreach of services primarily for the vulnerable populations of the women. Next. So RCH, as we discussed, essential obstetric care, emergency obstetric care, 24-hour delivery services, PHCs, medical termination of pregnancy, MTP Act, control of reproductive tract infection and STDs, and drugs and equipment kits, they were supplied at various levels as follows. Next. They were the kit. Next. To run all these programs, these kits were supplied to all the peripheral centers. So these are the kit that will contain normal delivery kit, equipment for assisted vacuum delivery, assisted forceps delivery, surgical set for minor procedures, manual aspirations, IUCD insertion kit, equipment and reagents for essential laboratory services also provided. Next. Same thing. Next. And also the RCS services covers essential newborn care, oral hydration therapy, and prevention and control of vitamin A deficiency in children. Also, these programs there for the children care. Next. So phase 2 began from 2005. The focus is to reduce maternal child mortality and morbidity with emphasis on rural health care. Also, major strategies where definitely everybody should go to the institutional. There should be no home delivery at all. Institutional delivery, skill attendance at delivery, emergency obstetric care, optionalizing the first April units, and by operationalizing PHCs and CSCs for round-the-clock delivery services. Next. So these were the FRUs. Next. And these were the first referral units which should be strengthened with availability of surgical interventions, newborn care, and blood storage facilities for 24 hours, so that the uh, pregnant and the woman should not be devoid of any complications. Next. New initiative is trainings of these MBBS doctors, and recently also they have launched this CHO program. Actually, they are developing the community health officers in what in they have been training the BMS and other doctors for 6 months at the district hospitals in especially the gynae of skills and the pediatrician skills, and they were giving postings at the remote areas where they allopathy doctors they are not available, and they will be serving at least for the basic obstetric and newborn care. They are the CHO program nowadays, what is recently launched. Next. So general Surakshana, especially that meant for the help of the pregnant woman, and also in this the remuneration is also paid. These are the low performing states where the institutional delivery are very less, and high performing state where institutional delivery are fine. They have been providing this remuneration to the mother around 2000. Next. Fine. Next slide. Next. So these are all the facilities under RMN CHA program. Now the Vande Mataram scheme where the private obstetrics and gynae hospitals also can volunteer. Enrolled doctors will display the Vande Mataram logo at their clinics, and iron and folic acid tablets, oral pills, treatings will be provided for their free distribution. Next. Next. So RCH we already discussed. Next. So these were the nutritional programs for adolescent girls for prevention of the anemia, basically, and the undernutrition in the adolescent girls. So these were the services. Beneficiaries will be adolescent girls less than 35 kg and pregnant women less than 45 kg. The aim is to improve nutritional and health status of the adolescent girl. It comes with 100% central assistance. Next. Again, nutritional anemia prophylaxis program was launched during the 4th, 5th year plan, and prevention of nutritional anemia in mothers and children is the main motto of this program. Next. Again, same the beneficiaries, children and expecting and lactating mothers, and family planning IOD acceptors. Expecting and lactating mothers as well as IOD acceptors, 60 mg of elemental iron and 0.5 mg of folate every day for 100 days is provided. And for children also elemental iron and folate is provided. Next. Again, weekly iron and folic acid supplementation programs for adolescent to prevent the anemia. As Dr. Bodhankar sir was saying, the statistics and all the numbers for these anemic adolescent girls and ladies, they are rising. These programs will be really helpful for everybody of them. Next. Same IFS tablet and will be given, and biannual deworming is also done. Next. The nutritional program for adolescent girl, again this Kishori Shakti Yojana. These common service are watching over menarche, immunization, general health checkups, training for minor ailments, deworming, prophylactic measures against anemia, goiter, vitamin deficiencies, etc. will be provided to them. Referral to PSC district hospital in case of acute need, and girls also provide supplementary nutrition for remuneration is also paid to them. Next. So these are the references. These were the programs. I will summarize in a minute that what we seen is Janani Shishu Suraksha Karyakram, Rashtriya Kishor Swasthya Karyakram, Rashtriya Bal Swasthya Karyakram, Universal Immunization Program. One missed was the Mission Indradhanush that is launched by our PM, that is meant for the vaccination campaigning, that is catch up vaccination. So we see the missed vaccination children in this, and all the districts has been divided with proper pediatricians. They have been given the charge and they will supervise this Mission Indradhanusha. Janani Suraksha Yojana we have seen. Again was the Pradhan Mantri Surakshit Matritva Abhiyan, Navjat Shishu Suraksha Karyakram, NSSK. By this, all training is done at the district hospitals, women's hospital for the newborn care, and also national program for family planning is this. Next. Next. So now only one program that I will discuss for 1 or 2 minutes is this national mobile unit that is running in our district also. And I was fortunate to be the part of that team. That national mobile unit, what they do is the pediatricians and the gynecologists will go to the remote places with this national mobile unit van, which is having all the facilities for the normal deliveries and some surgical interventions and also the newborn care also. So I have been the part of this. Next. We can see the gynecologists from our Amravati regions also and their assistants. And what the success story of this was, luckily or fortunately, we were able to deliver a lady that came at term to the checkup, and we can successfully revive the baby there itself. So that was the success story for this medical mobile unit. That is the one of the women's health program run in India. Next. Next. So these were our visits during these mobile medical units for the pregnant and lactating mothers or female health. These were the program run for the mental health, whichever girls and ladies, they are staying at the some ashrams and all that. So this program is run basically by the government, where a psychiatrist, gynecologist and pediatrician visits twice a year to these centers where they have been kept, and they will take care of their general health for the mentally challenged girls and females. Next. And last but not the least, this is the nutritional rehabilitation program that has been run for the SAM children, severe acute malnourished children from 0 to 6 months and 6 months to 5 years. That has been run totally by the government assistance and all that. So I conclude my topic here. We have covered all the necessary programs for women health and children health also. Any queries, they are welcome.
Thank you, Dr. Nitin sir, for sharing your valuable information and of National Health Program for Women and Children and recent new initiatives taken by the government. We are privileged to have Dr. Sonali Shirbhate ma'am for today's CME. She is consultant pediatrician at Super Speciality Hospital, Amravati. She is state executive member, Maharashtra IAP 2022 and co-chairperson Women Committee, Maharashtra IAP 2022. She was past president at IAP Amravati 2018. She has bagged various prestigious awards like Golden Aim Award for Healthcare Excellence 2022. She was bulletin editor for Maharashtra IAP Bulletin and co-editor for Mahapedicon 2019 Souvenir. It's a saying, my mom, what that word was. So true it is. So we are privileged to have Dr. Sonali ma'am with us, and I would request her to please begin her lecture. I welcome Dr. Sonali ma'am.
Thank you, Mrunmay, for such a wonderful, you had given my CV. I am not like that much, but you had told too much for that. Thank you very much. First of all, I would like to thank you, Dr. Satish Agrawal, sir, because he has given me this concept to for the presentation, as well as he has told me many of the points which I was not knowing actually about this topic. Thank you very much for the opportunity given, as well as I will like to thank Dr. Naresh Tade sir, Dr. Sushil for this CME. Can I share my screen, Prakash ji? I am not able to actually. Please able my screen sharing, Prakash ji. Okay. So moving towards our topic, mother as a role model. Every mother in her life is always a role model for her child. Next, yeah.
So you may have cursor in your hand, so you may move the slides as per your wish.
Okay,
you may
okay.
move cursor, yeah.
No, I am not able to do it, sir.
Okay, Prakash ji will do. Prakash.
Ask the host to give the permission as is coming in on my screen. So the points taken over here are mother as a role model, especially for the adolescent girl child, as well as some of the points we'll be sharing on the responsibility of both parents. So let us divide this topic into 4 categories. My mother, my role model, always there is this concept in every child mind. But for our upcoming mothers, as well as the mothers of here in this presentation, we would like to share some of the points for the moms to be a role model. Of course, she is a role model, but I would like to share some of the points to this mother as well as the upcoming mothers. So I will like to divide in these 4 categories: working mother as a role model, especially for a girl child; then role model for physical health development of child; role model for mental and emotional health of child and adolescent; and role model for social aspect of development, especially communication skill and stress management. Next. So see the work of the mother, which is very vast. She has to stay calm in each and every situations she is facing, as well as she has to monitor the children in daily household chores. So moving to the topic, the working mother is still a strong work of ethic in their children. Especially she laid the foundation in her child as well as in the next generation for the commitment and shouldering of the responsibilities. Next. Mothers teach their child not only the household chores, but also how to make the time management better. Kids learn time organization skill, seeing their moms successfully manage their work at home as well as the workplace. Next. So mothers teach their child how to shoulder a responsibility. Excuse me, it's running too far. How to shoulder the responsibility, as well as the working mother child gets in future a responsible individual and manage the responsibilities very much. So moving on, back please. Moving on to our second category of role model for a physical health of a adolescent girl child or as well as an adolescent. So a mother shares her responsibility or sets a role model, especially by implementing herself in exercise activity as well as in the physical activities, especially like cycling or running or like volleyball, etc. Playing with an adolescent or kid, you set an example by setting increasing the physical activity which is needed for an adolescent girl or an adolescent, especially which will help his physical development. Then comes the role of the nutritious food she is doing, and she is implementing the concept of nutrition food in her child, especially at the breakfast, at the meal time. She would involve an adolescent, especially teach her how to select a nutritious diet, nutritious food like yogurt, grains, cereals, nuts, fruits, nuts, etc. in the diet, as well as she will involve all the family members in the meal time, especially cutting the video, the screen time and all the TV sessions, especially at the meal time. So she will set a role model next for the selecting of the nutritious food. Then comes the role modeling. She will also implement that certain foods should not be forbidden, especially in front of the adolescent girl, because it will create a same sort of bad behavior to her in her future life, to forbid some of the foods. Then she would tell her adolescent and she would teach her adolescent about the mindful eating, whether the stomach is a bit hungry or it is comfortably full or uncomfortably full. By this concept, she will set an example of mindful eating, as well as she especially when the family is dining out in the restaurant, she would help an adolescent girl to select specially all the diet and nutritious food, especially and the soft drinks and the beverages which are nutritious, especially for the girl child and as well as for the family. And of course, the television and video games are to be forbidden next at the time of meal. She would do this and setting an example for the physical development of the child. And then comes the cosmetic and body images. Especially adolescent girls are very conscious about the cosmetic and body images, about the use of cosmetics, about the pattern of garments and the body images. But remember, dear mothers, this may be due to some ongoing problem in the school or in the family, that girls may be more conscious of the body images. So you have to look into the matter, whether she is just disinterested in her body image or it is some other problem. Then use of cosmetic and dressing patterns. Next, mother can help her adolescent girl especially to select the garments, but the whatever she is mother will be teaching the girl child, but always make aware that do not made her aware about her own appearance, or do not ridicule her or put down about the bad role models of the girls which she is admiring, and always acknowledge and the dissatisfaction and see the problem of friends or at school. Maybe it may be appearance related something issues in the school. Next. So, and especially mother can set a role model, especially the menstruation, when the girl child development and menstruation start. She can help her in sorting out all the problems of the premenstrual syndrome, of the abdominal pain and etc. And she would tell her experiences, so that the girl child could learn about lot from her mother, and so the mother can set a role model for this also. So whatever you teach your daughter, but what the dressing style or makeup she is doing, but teach her that inner beauty and intelligence skill matter the most. And second thing to be taught is the dignity should be maintained. What are the dressing style and the makeup you are applying, but there should be a dignity. Next. Coming to the third category of mental health and in children and adolescents, good mental health is important for the healthy teenage development. Next, and the strong relationships. But let us see some of the points about the how to remodel the emotional changes in adolescent girl and adolescent, especially because the adolescence is a big time of social changes, emotional changes. Let us see some of these changes we all should know, so that we as a mother could remodel our adolescent, as well as it will help us in the future. Next. These are the some social changes in adolescent, like identity issues. Always the adolescent are concerned about, or the independence, especially they want to be independent individual, and they want to set an example and spend like money on their time also, but they want to be always an individual. Next, independent individual. I'm trying to do this, but I'm not able to. Adolescents are sharing their new experiences and especially risky taking behaviors they have. They have their own limit and abilities. They want, they have to set their own values and morals. Especially adolescent developing brain are into it continuously. Next. Then influences, especially friends and peers, might influence your child and your adolescent, especially in self-esteem and self-interested. And also your adolescent maybe have a romantic relationship or maybe a dating. These are the some of the slides I have shared that so that we mothers could know. Next, about this, the emotional and social changes of the adolescents. So media impact is also there, especially social media risks and internet safety comes into to the point, especially for the adolescent. The internet has a big influence on our adolescents. So mothers have to look after their, keep an eye, but you have to also maintain that the privacy and the space you have to give to your adolescent. Then the adolescent might want to be a responsible individual. Next. So these are some of the emotional changes in adolescent, like moods and feelings. So mood swings are there, strong and intense emotions. Some it might be sometimes unpredictable for the mother. Then they are very sensitive to the issues, especially some of the issues the child is facing, and they are not keen to read the facial expressions and the language of the others. So they may be at faulty. So you have to understand these emotional changes of the adolescent. Next. Some of the other emotional changes are like self-consciousness and self-esteem, decision-making, especially of the adolescent. They are making the decision-making skills. Next, and are still developing. They are still learning in stages. So now this is the most important slide. What we have to learn that these are the some of the good mental health signs of the adolescent girls, which every mother should know. And the signs are that they feel happier and more positive about themselves and they enjoy life. They bounce back from the upset and disappointments. They have the healthier relationships with family and friends. They do physical activity, eat a healthy diet. They get involved in the activities. They have sense of achievement. They can relax and a good night's sleep, and they feel like they belong to there. So these are some of the good signs every mother should know, so that she could come to know the what are the what are the bad signs, or what are the signs that adolescent may need a help. So some of these are the signs I am describing here may need the adolescent the help, or adolescent girl child may need help, and mother can be a role model by setting an either she should communicate with the adolescent, or she should take help of the her partner or some school teacher or social worker for setting the good issues in the mentally ill child. So some of these points are like sadness, a lot of time, drop in school performances, ongoing worries and fear, aches and pains. They don't go away quickly. They are avoiding friends and social contact. They are doing less at school. They are being aggressive and antisocial every time in every aspect. They are saying that pains like headache, stomach, backache, they are not going. They are very anxious. They are aggressive consistently. These are the signs of bad mental health, especially in adolescent. Next, which needs help. Then what the need of this help? We can take the next help from our peer group of the adolescent, but mind well there should be an like an elder sister in that. Or next, the help might be taken from a school teacher or from a practitioner or a doctor, or there are the counseling sessions taken by a known counselor for the adolescent. So next. So you have to set an example by telling your adolescent that the problems might occur. When I was adolescent, I was also in the same problem, but I handled like this. So when I have a presentation, I was also in the stress. I'd handled like that. When I started presenting, I came to know that it is very easy. Or you can share your points and experiences with your girl child that this might could happen. This had been happened. This was my mistake. Admitting mistake is also a setting and role model for a child, so that she could learn from you. She or he could learn from you that and consider that mother is helping her. So these are the many professional support options like your GP, school counselor, psychologist, social worker, your local community healthcare, or local mental health services. These are the next many professional supports for the. But you have to set an example by always communicating with your adolescent girl. Next, that it's very important to deal with the issues. So the key points of the mental health development of child, and you can you can be a role model for this. Strong and loving relationship can be a direct and positive influence on teenage mental health. Physical health is a key to mental health. If you are concerned about your child mental health, start by talking to your child, and there are many support options also. Next, you can encourage teenagers to stay active and avoid certain bad habits. So now coming to the fourth and last category about the role modeling for social development and communication skill development and stress management. Next. So key points here, I would like to tell that preteens and teenagers are forming an independent identities as we had discussed. So, and positive relationship between parents and teenagers are important for the social and emotional development of adolescents. Next. So some of the main points are described here because as it is a vast topic, everything I was not able to take here. Except the friends if the adolescent girl child is having, but keep an eye on that circle so that you should come to know if there is something fishy. Then teach her in a setting boundaries about the relationships she are having. Do not scold or hyperreact to the choice of friends by her. Next, you have to teach your adolescent girl especially that when to say no about certain things like physical intimacy and contact. Try to convince her in a proper silent way if you find fishy in the friend circle. If there is a romantic relationship, you have to give her space, but you have to keep an eye which she doesn't know about that, because giving space is also most important. Then trust is again a most important factor, because if you are don't trusting, then your relationship with your teenager might be faulty in future. Next. So stress management problem and problem solving skill has only one answer to this, and that is a communication by mother and parents. Mother is the specially a role model next for this, because in the stress management she can communicate and only communicate which will solve the problem. Then start talking to your daughter at the young age. Talking to your daughter is most important because it will solve many of the problems. Then having an open mind will help her to talk about you. You have to set an open-minded example of open-minded mother. Discuss everything about about the problems your girl child, your adolescent is facing, so that she could tell you about the all the problems. Then find a balance between friend and a mother, because if you are trying to be friendly too much, but there are something like mother can be a friend and can be confident, but she always remain a mother. Trying to be too close to your daughter is can be a counterproductive. So you have to maintain a balance, and this is the especially the role modeling which mother is doing, because she is maintaining the balance, so especially because overprotectiveness is also a biggest problem. Next.
Sorry for the interruption, ma'am. Only 2 minutes remaining.
Yeah. So sharing a family rituals and looking solutions for your daughter. Next, we are the most important, because you are giving time to your adolescent. Next. For this in the problem solving skill. So the last one, the building confidence in the preteens and adolescents is the most important factor, because if you model confidence is in your own ability, you can be set on a role model for this and encourage your child to act confident. Tell her some of the examples next. of you are facing and how do you tackle with that. We'll set a model confidence for the adolescent. Next. So here are the for some of the tips for the perfection in role modeling for especially mother. Next. So try to do things you say to your child because teenager will follow you. Try to include your child in family discussion. Talk open-mindedly. Let them be in your decision. Take the decisions as well. Keep a positive attitude. Your child is learning from you. Take the responsibility by yourself for admitting your own mistake so that child will learn to admit and to solve the mistakes also. Use the problem solving skill and set an example for them how you tackle with it. Last slide next. So here are we shared some of the practical tips next for the role modeling, and I hope it had next help everyone for role modeling. So at the end, I would like to say my mother has taught me the hard times can be overcome and losing battles can be won. So these are most important. My mother as role model, and I'm also trying to be a role model for my child also. Thank you. Thank you very much.
Thank you, Sonal Shirbat, ma'am. So, thanks to all the speakers for this session, and the information provided by the speakers were excellent, and we got deep insight for all these topics, and this will surely help us to tackle the problems related to women health in future practice also. So, great thanks to Dr. Neeta Mundana madam and Dr. Murmai Bobde madam for chairing the sessions, and thanks to once again all the speakers also. And now we will move towards our next session. And for the session, we are we'll have Dr. Lakshmi Bhon madam, who is the pediatric intensivist and director of the Parijat Multispeciality Pediatric Hospital, and we will be discussing two important topics. The first one is the common surgical issues in women by Dr. Seema Sune madam, and the second one is the mental health issues of the elderly woman by none other than our psychiatrist Dr. Vikram Wankhede sir. So over to you, Dr. Lakshmi Bhon madam. Lakshmi ma'am, are you there?
Thank you, Rishikesh sir, for your kind words. We are honored to have Dr. Seema Sune ma'am with us as a speaker for today's CME. Moving ahead with the flow of the CME, Madam has done her MS, FMAS, general and laparoscopic surgery. She is a practicing surgeon for last since 30 years. She's a director at Sune Hospital, Amravati. We must say she's breaking the bias in the surgeon's field. She's an executive member with Herba Surgeons Association, and she's vice president, Surgeons Association, Amravati. She was ex-surgeon at Government Hospital, Amravati, and she was ex-lecturer at Government Medical College, Nagpur also. Today's topic is, though we say it is common, but we must say it is a neglected one also, neglected aspect, and utmost important, that is common surgical issues in women. So over to you, ma'am. She's great. Dr. Seema ma'am, are you
there? And just sharing my screen, just a minute.
Okay.
I'll be rejoining in a minute. There's some issue. I'll just rejoin.
Okay, ma'am. Definitely. Some technical issues are there. Yes.
प्रकाश मॅडमची स्क्रीन शेअर करू शकतो का आपण?
करू शकतो पण मॅडम म्हणाले मिस करते.
अच्छा ठीक.
हो मी त्यांना केलता कॉल.
Our next lecture will start soon. Thanks for your patient waiting.
So till the time Madam joins, we have Dr. Tuteja sir with us. Dr. Tuteja, would you like to say something about the ongoing CME?
Am I audible?
Yes, ma'am, you are audible.
Thank you. Greetings to one and all. First of all, I need to say sorry. It took some time as I had to again log in to share the screen. So sorry for it.
No, it's okay, ma'am. You can continue.
Thank you. Good morning, everybody. First of all, I would like to thank the organizers for giving me this opportunity to participate in this esteemed CME, and that's on women care. I'll be speaking on some common, or yes, you rightly said, Lakshmi, that on some neglected surgical issues about women. Now, as we all know that amongst all the issues, breast lumps, they lead, and malignancy of breast tops the list. As a result of which, many a times we've seen that there are so many breast cancer awareness programs and educational programs, and even a month has been dedicated to its awareness. I'll be speaking on that mainly, and I'll be including some other perennial conditions into it. Now, whenever a patient of breast lump comes to us, the approach is as it is in other cases too, the history taking. Over here, it's the age, the number of the children, whether the patient is lactating or not, what is the onset or duration of the lump, whether it's unilateral, bilateral, how is it progressing? All of these are the points that we need to take care of it. As we know that most of the breast lumps can be malignant or they can convert into malignancy, we need to evaluate the risk factors. Now, this is because even a breast lump, which is today may be benign, if we leave it like that, it can become a malignant tomorrow. So we need to know if there is a strong family history of cancer breast, if the patient is on oral contraceptive pills or hormone replacement therapy, if there is an early menarche and late menopause, because of this, the endogenous estrogen remains in the body for long. Whether the patient is nulliparous, is there a lack of breastfeeding? Now, this is usually seen nowadays because of the increased working women ratio. If there is an excessive alcohol intake or smoking. However, what I've seen in the practice is 80% of breast cancer occurs in women who are not at an increased risk. Now, once these two things are ascertained, the proper history and the evaluation of risk factors, what we come across is the examination. Now, as the slide shows, the whole breast is being divided into 4 quadrants: the upper outer, the upper inner, the lower outer, and the lower inner. Now, whatever percentages have been shown, they're not of the malignancy, but of the lumps that can occur in these quadrants. The upper outer can have 60%, upper inner 12%, lower inner 6%, lower outer 12%, 10%, and subareolar 12%. Once we see the lump, we need to ascertain how it is. We need to assess the lump, whether it's regular, it's smooth, whether it is firm, it is hard, whether the skin is normal or there is dimpling over there, whether there is warmth over there, whether there is change in the size of the breast, whether there is a discharge from the nipple. If it is so, what color it is, whether there is dimpling or puckering of the skin. After the complete examination, if we find that the lump is firm or rubbery, it's regular or smooth, it's not fixed, it's mobile rather, the skin is normal and the discharge of the nipple may be there. If it is there, it's green or yellow, but not bloody, or it's not there. We can slightly have a conclusion that, or we can slightly come towards a conclusion that this is a benign lump. Now, when we talk about the benign lump, what are usually seen are fibroadenomas, which are usually seen in the younger age group, clusters of nodules of the fibroadenosis, which is usually seen in middle age group or towards between 20s and 30s, as it is responsible for the hormonal changes in the body. We can have simple breast cyst, or we can have galactoceles. Now, when I talk about galactocele, it's something which I have seen is that usually in the lactating period, and specifically after the delivery or in the PNC period, there is milk engorgement, and that is because of the ducts are getting blocked. Now, every household lady knows that this is milk engorgement, and usually what they do is they try to do the household remedies. Now, here we need to tell them that if you ever feel like that, please consult a proper medical person. This is because in the initial stages, although we know that this galactocele can be absorbed once lactation is stopped, but during lactation, as the milk is rich in nutrient, it can become infected. And many a time in the initial stages, what we can do is simply aspirate it and continue with the lactation. But what I have seen is in most of the cases, they come with huge abscesses with all separation. And finally, we have to go in for surgery. We have to go in for incision and drainage. And the wound should close. So we finally end up stopping the lactation. Now, this something can be avoided if they're well informed that they need to consult a doctor even during lactation. Even if they feel that this is a milk engorgement, they need to consult a doctor so that a proper treatment can be given at a proper time. Now, if the next slide. Now, if the lump is hard, painless, irregular, or it is fixed to the chest wall or the surrounding tissues, if we see something called as pudy orange, that is the skin dimpling, if there is a retraction of the nipple, if the nipple has got a discharge, but it is bloody in nature, we should think of it going in towards malignancy. As we can see from the diagram, we can see a lump, a pulled in nipple, the dimpling of the skin, and the bloody discharge and others. This just shows that we are heading could be malignant lump. The incidence of malignancy of breast in women is very high. It is as high as 30% of all cancers in the women. Frankly, it is steadily increasing with the frequency of the age. Now, as if we imagine that women are reaching the age of 90 years, then practically 1 in 8 or 1 in 9 women are going to develop breast malignancy. However, the treatment is successful in 3 out of 4 cases. And it's also been seen that it's very rare below the age of 25 years, but somehow, sometimes exceptions can be there. No malignancy has got a specific reason or a causative factor which we can point out that this is the cause and that is why a person has developed malignancy. Now, same stands true for breast malignancy also. Over here, there are genetic factors which are predisposing, specifically, as we know, the BRCA1 and BRCA2 types of genes. Now, these are the tumor suppressor genes. Like if they have not mutated, the tumor cells do not grow. But then if any one of them gets mutated, this suppression is stopped and the tumor cells or the abnormal cells start growing up. So that is the genetic factor responsible. Hormones, presence of estradiol or endogenous estrogen for a longer time is equally a predisposing factor. And over here, if you have an early menarche with late menopause, it's definitely the estrogen remains for a longer time. Sometimes females do get exposed to various radiations specifically for any other reason. In such patients, chances of having a breast malignancy are much higher as compared to others. Now, as usual, the malignancy has been divided into stages. It is right from stage 1 to stage 4. In stage 1, and usually in breast malignancy, it is the size of the tumor and the lymph nodes which are responsible in dividing into stages. Now, when the tumor is less than 2 centimeters, usually it comes in stage 1. However, after surgery, if you find that some lymph nodes are there or some cluster cells of malignancy are seen in the tumor, it can be stage 1B, but usually it's stage 1 only. The moment tumor size starts increasing, it's more than 2 centimeters, but less than 5 centimeters. The moment lymph nodes start getting involved, almost up to 1 to 3 lymph nodes, it becomes stage 2A. In stage 2B, usually the lump is more than 5 centimeters, even if it is less than 5 centimeters, but if the lymph nodes are larger, more than 1 to 3 lymph nodes, it's usually stage 2B. Then we have stage 3. Here in stage 3, we have A, B, and C, all the 3 stages. In stage 3A, the tumor is always larger than 5 centimeters. The lymph nodes are between 4 to 9. Now, even if there is no tumor, but the lymph nodes are positive and they're between 4 to 9, it's always called as stage 3A. The next is stage 3B. Here, fixity starts coming in. That means the surrounding tissues are getting involved. Now, whatever may be the size of the tumor, but in case it's ulcerated, even if it is 2 centimeters, but ulcerated, it's going to be into stage 3B. Stage 3C, whether the tumor is present or not, but if the lymph nodes are present below the clavicle and above the clavicle, it's always stage 3. And as we all know, stage 4 is nothing but metastasis by blood, lymph, or locally extension. When we talk about histopathologically, these malignancies have been graded into grade 1 or a low grade, where more of the cells are towards normal and they grow very slowly. Grade 2 is a moderate type, where cells look more abnormal and they grow slightly faster. And grade 3 is the higher type or the high grade 1, where the cells are atypical and they grow up very quickly. Now, histopathologically, this could be an invasive carcinoma or a non-invasive carcinoma. It could be a lobular carcinoma, or it could be a ductal carcinoma. Now, whenever it is through the milk ducts, the lining is there, it is invading the surrounding tissue, it becomes invasive. And if it is not invading the surrounding tissue, it becomes non-invasive. Coming down to the investigations, once we have ascertained that this could be a malignancy, we go ahead with the investigations. For breast clump investigations, triple assessment is always a choice because it gives a confident diagnosis in 99% of the cases. Now, what is this triple assessment? This includes a complete clinical examination, a proper imaging through ultrasound and mammography, and a complete histopathology with either by FNSE or by a core cut. With this, once we have diagnosed, we need to have a treatment part, and definitely breast treatment has got all the modalities available now. It has got surgery, it has got chemotherapy, it has got radiotherapy, it has hormonal therapy and the targeted therapy. All these are there to see that we get the best results and we increase the life expectancy. That is why sometimes I tell my patients, okay, fine. If you are having a breast malignancy, nothing to worry about. It can be treated in the best possible way. For surgery, when it comes to breast conserving surgery, it could, nowadays we have just need to remove the lump. It could be lumpectomy, or partial mastectomy. Mastectomy, the surgery needs, the whole breast is removed. It could be a total mastectomy, a modified radical mastectomy, or a radical mastectomy. After surgery, it's normally what we prefer is chemotherapy. And here the drugs are being given to stop the growth of cancer cells. Now, this could be systemic chemotherapy or regional chemotherapy. However, in cases where the lumps are very large or the growths are inoperable, this chemotherapy can be given first so that the lump size is reduced, followed by surgery. After surgery and chemotherapy comes the role of radiotherapy. Now here, high energy X-rays or other radiations are being used. That could be an external radiation, internal radiation, or a proton beam therapy. Coming down to the hormone therapy, which is now very much upcoming. This is usually given before surgery and chemotherapy. Specifically in premenopausal age group, it has been found that if it is given, practically the death rate reduces between 17 to 30%. So it's a very high improvement and it is very much advocated nowadays. Now, some hormones we see they can cause cancer. So this hormone therapy lowers the levels of these hormones or blocks their action to stop the cancer cells from growing, as it is seen from this figure. And the most important now coming with the latest one is the target therapy based on the biological theory. There is certain protein called as HER2 or HER, that is human epidermal growth factor, receptor 2. It makes the cancer cells grow. With biological therapy, it works by stopping the effect of HER2, and that is what is the targeted therapy. Now, this is all about the treatment. In short, whatever we have, and this gives one of the best results for the cancer of breast. Well, diagnosing a cancer of breast or malignancy of breast, giving it a proper treatment, this is not all what we aim. What our aim is much above that, and that is thinking beyond pain. We need to reduce the incidence. We need to try to prevent this as much as possible. And that is what I say is thinking beyond pain, thinking beyond the diagnosis. Now, this can be achieved by promoting self-examination of the breast. Now, whenever you tell a patient about self-examination, what usually happens is they either start doing it daily or they start doing it weekly, and practically there is a panic situation. One day they feel they have a lump, another day they feel it has grown larger, third day they are unable to find it. So there's a panic situation. Now here we need to explain them that this self-examination has to be done in a proper way and just once in a month. And that is usually an opposite hand is used with the palm of the opposite hand is used for the other breast. For example, right hand for the left breast and left hand for the right breast can be done in front of the mirror too. But they have to be assured that this is not supposed to be done on the regular basis. The next is prevention. Yes, we need to see to it that whatever are the predisposing factors, we should try to limit them or reduce them as much as possible. For example, we can promote breastfeeding because we have seen that if there is a lack of lactation, yes, the chances of developing malignancy are higher. Breast cancer screening should be done regularly. The hormonal therapy should be reduced. It's very common nowadays for HRTs, but this should be reduced. Although I do agree that the benefits of hormonal therapy are much higher as compared to their chances giving a malignancy, but still it is one of the predisposing factors. So why not reduce it? Why not limit to it? Now, reduce alcohol consumption. Initially, this could have been limited only towards the waist. But what's happening, even in our culture, this is coming up. Now, why it should be reduced? Because statistically, it has been found that in Western culture, in Western places, where this is of a high rate, the death rate is practically between 3 to 5% in women because of malignancy. So that has been found as one of the predisposing factors. Physical exercise, yes, for all the reasons it's important. But the other reason is whenever there is obesity, the hormonal steroid of the body fat is being converted into estradiol, which is again a predisposing factor. So now, by looking into all these aspects, at least we can try to reduce the incidence. We can increase the immunity of a female so that the incidence is reduced. Athav, please. The screening of the breast, what we can do is by mammogram every 2 years for the women between 50 and 74 years. For clinical breast examination can be done every year by a specific doctor for a woman above 40 years of age. Now what happens? A CA breast has been diagnosed, but then still the incidence of death rate or the complications is increasing. This is because many women do not take a complete treatment. And this is because of the myths which are prevailing within the society or amongst the female community. Usually it is surgery will cause disfigurement. Now we have to assure them over here that this is not so. With coming up of breast reconstruction, with coming up of breast conservative surgeries and implants, disfigurement is no more a taboo at all. It's not going to be there as long as you take up a complete treatment. They have this feeling, radiotherapy and chemotherapy is very harmful. They may not sustain it. It's not like that. We need to assure them, we need to explain them that radiotherapy and chemotherapy, in case a proper diet is taken, in case a lot of fluids are taken, all the nutritional supplements are taken, they have much more benefit than the side effects that a patient is going to face. And these side effects remain only as long as the therapy is going on. Like discoloration of the skin, pigmentation of the skin is there going to be there only till the radiotherapy. Once it's over, gradually the skin is going to come back towards the normal. Similarly, a lot of people are scared about their hair fall because of the chemotherapy. That is going to be there. I don't say it won't be there. It can be reduced by the supplements, but then the hairs do come back immediately after some time once the chemotherapy is stopped. So this all has to be put into their minds that they are not supposed to be scared of this. The moment I tell a patient in a OPD that fine, you have got malignancy and we need to do further things, you see the face and you feel as if their life is lost. We need to assure them that today, even in stage 4 malignancies, because of the new adjuvant drugs, the life expectancy is much higher, and it's nothing like that. Their life can be as normal as what it was yesterday before the diagnosis of CA breast. Now, this is what I would like to talk about CA breast in short. Why I took up this topic of perianal conditions, that was because in my clinical practice, I've seen for last 30 years, what I'm seeing is, now these conditions are very trivial and can be managed very nicely, but I see patients coming, neglecting it, coming in extremes of stage with lot of anemia. Even the hemoglobin drops down up to 3 to 5%. Some perianal region that we require only a day's treatment takes up a week just because they need to be given a blood transfusion. Now, why is this so? That I personally feel that is because females are shy of sharing their perianal conditions or disclosing their problems, even to the relatives, even at home, and so as to the doctors. They really don't want to get examined. Many times it does happen that being a female surgeon too, they come and say, madam, is it really necessary that you need to examine? And then I have to convince them that yes, it is necessary for them. Now, usually perianal conditions which are faced are anal fissure, hemorrhoids, fistula in ano, pilonidal sinus, and others. But of all these, it's the anal fissure and hemorrhoids which top the list. Now, that is because there is persistent bleeding, acute bleeding, chronic bleeding. When there is a chronic bleeding, the patient may not even daily notice it, but gradually the hemoglobin starts falling down. A stage comes, they go into agony with severe pain. Now, what is fissure? It's just nothing but a breach in the continuity, as we know in the ano term. Now, the causes are strained evacuation of hard stools. That could be because of the dietary habits. lack of water intake, lack of fibrous diet. What I have seen as the ratio of working women is increasing, what's happening is women are usually very shy of taking up using the public washrooms or the office washrooms. So what they do, they don't take water. They'll just have water in the morning and once they come back from the office because they don't want to use it. What's happening when they're traveling? They don't want to get down. They don't want to use the public toilets. So again, there is a lot of water intake is reduced. What's happening? There's a lot of dehydration. And as we know, it causes constipation. Lack of fibrous diet, specifically in the younger generation where they're going out with the junk foods. The women will take care of everyone that they need to get lot of fruits, vegetables for others, but for them it's the leftover sort. So there's a lack of water intake, lack of fibrous diets. It can also be seen during pregnancy because as the weight is increasing, the weight of the baby is increasing, constipation is there, or due to lack of support of the pelvic floor following a vaginal delivery. Please.
Sorry, ma'am, to interrupt. 2 minutes remaining,
Yes.
ma'am.
The usual features are constipation, severe pain on anal defecation, and fresh blood. Another cause, the treatment in the early stages is adequate fluid intake, and in the later stages, surgery is required. Whenever we are advising sitz bath, please see to it, we tell them that they need to wipe it dry after sitz bath so that there is no pruritus or a fungal infection. As I said, the other causes, hemorrhoids, which are nothing, swollen and inflamed veins. They go on in same causes are there as in anal fissure, straining, obesity, pregnancy, low dietary fire, and same reason when it becomes, a patient becomes anemic because of the severe blood loss. Now, usually here patient comes with severe pain. My saying is, why feel so much of pain? Why bear so much of pain? Why not consult a doctor earlier? Why shy off? And this is what we need to tell the women. My take-home message will be, women need to understand that their well-being is very important. They need to give the same importance to their health as they give it to other things like profession, family. They need not shy off in discussing it with right professionals and taking proper treatment, and need to keep in mind that every ailment has got a remedy. And we as doctors and responsible citizens need to spread this awareness and motivate them to keep their health concerns as a priority at right from childhood to old age. Thank you very much.
Thank you, ma'am. Thank you for such an elaborative talk. And the message is very crystal clear, thinking beyond the pink. And though it is like just a tip of iceberg, we are looking towards it, but it is a gravitating issue. You have discussed it till now. And the best part is that all the modalities are available. We salute to your zeal and passion towards your profession. Thank you very much, ma'am.
Thank you so much.
Moving to the next topic, our next speaker is very young and dynamic, multi-talented person, as we know him all. He has done his MBBS, MD, and DPM. He has worked at Jagjeevan Ram Railway Hospital, Mumbai, at Sion Hospital, Mumbai also. Work as basic medical scientist at Ethic Committee, Holy Family Hospital, Bandra. Clinical research coordinator in many international clinical trials. He's currently working as consultant psychiatrist at Antarman Mind Care Center, and he's honorable secretary also of Amravati Psychiatrist Association. He's an executive member of IMA Amravati. His topic is need to consider the mental health issues of elderly women. So I welcome you, sir. Over to you. Dr. Vikram Bansal, sir.
Yes. Thanks for the kind introduction, ma'am. May I request to share my screen? Yes. Okay. Is it visible to all?
Yes, sir.
Okay. So, shall we start? Am I audible properly?
Yes, sir.
Okay. Thank you very much for the kind introduction. First of all, I would like to thanks and congratulate IIP to organize this wonderful academic treat on this Sunday morning. So let's discuss an important but slightly untouched issue of mental health, importance of mental health in elderly women. Actually, in today's academic feast, IIP has served you a buffet of the different topics, and this is one of the different topics that we are going to discuss here. As we all know, with advancing medical technologies, we observe a high life expectancy rate. So globally, we see that the population is aging rapidly, and it is estimated that by 2050, the overall estimate of the elderly people more than 60 can be nearly double from 12% to around 22%. And that counts on to the mental and neurological disorder among the older adults for around 6.6% of the total disability for this age group. It is estimated that approximately 15% of the adult aged more than 60 is suffer from one of the kind of a mental disorder. We often see that elderly women experience the world through many significant changes throughout their lifespan. Because when it comes to addressing the mental health, it is slightly overlooked more than at any other age group. When we are compared to the younger adults, we see, yes. So when we compare about the mental health with other physical health problem, it is slightly overlooked than the other age groups because it is often masked by the underneath physical problem. Transition to the older adulthood is also a continuous journey that may find many of us find strenuous. So, my slides are not moving. No, it's not working. Can someone help, please?
Yes, sir. Please wait for a minute. It will be sorted out.
Yes.
Cursor is moving. Vikram, your cursor is moving.
Yeah, cursor is moving, but the slides are not moving.
Can you please reopen your presentation?
Yes. It's
working
right now. Yes.
Okay.
Yeah. So, what can be the risk factors that certain age group of the people that are prone to the mental health disorders, or that their age is or other morbid factors will it work as a risk factors for them? So, if we see that the significant ongoing loss in capacities and decline in functional ability with the age is a significant risk factor. That is, first of all, we can always say that the life events such as bereavement or a drop in socioeconomic status with the retirement, for especially for working class women, of course, is a biggest risk factor. The older caregiver women who usually care for their unhealthy partners are more vulnerable to succumb from the to suffer from mental health issues. Coping with the financial stress, loss of loved ones, and physical health can be a significant the psychological well-being of an older caregiver woman. There are other factors like when we see that the woman widowed, separated, or divorced may not remarry and prefer to live independently. So they face different kinds of stress or burden that affects their psychological health. We may be knowing about the emptiness syndrome when older women confront to the loneliness or a social isolation as the children moves away for their job or their settlement purposes. So they are more likely to prone for mental health issues. One of the most important neglected issues in our society or worldwide, we can say, is elder abuse. That can be a physical abuse, it can be a verbal abuse, a psychological, financial, or even a sexual abuse. That can be in a form of abandonment by the family, the neglect from the children, and the serious losses in form of dignity, serious losses of dignity and respect, and which takes the older woman towards the different mental health problems. If we can observe certain common symptoms in elderly women, we may help them to for their early detection of their mental health condition and to guide them towards a proper medical healthcare checkup as well as the psychological help. For example, the changes, if you observe the changes in the appearances or the dress that the person commonly wears, or the problem in maintaining the home or yard, we can be alert regarding something is wrong there. If we found that the elderly woman is confused, looks disoriented, or certain other problems she's facing with the concentration or decision making, we can find decrease or increase in appetite, changes in the weight, depressed mood, long lasting for more than 2 weeks is also a significant symptom for a depression. Feeling of worthlessness, inappropriate guilt, helplessness, thoughts of suicide, memory loss in the recent or short-term memory problems, physical problems that can't otherwise be explained, for example, chronic pains, aches, constipations, in which the physical examination doesn't reveal any significant abnormality. So that can alert us regarding the mental health problems. If the person is socially withdrawn, it lacks interest in the things that used to be enjoyable for her. So these are another significant signs that we can observe. If a person troubles handling finances or working with the numbers, unexplained fatigue, loss of energy, or significant sleep changes can be definitive symptoms for underlying mental health disease. We want to discuss here a few of our very common conditions that we usually observe in elderly women. Of course, the anxiety and depression is the most common mental health issues when we are considering this particular age group. The estimated rate of depression is 10 to 30% when we are considering the adults over above 60 years of age. We found that around 7% of the cases in the general older population are of unipolar depression and account for 5.7% of disabilities. Symptoms are often overlooked and undertreated because they co-occur with the other problems encountered by the older adults. Because we often see that there are morbid conditions, physical conditions that often mask these symptoms of depression, and that's why they are quite oftenly overlooked. Older people with the depressive symptoms have a poorer functioning as compared to those with the chronic medical conditions. So if two persons are having a similar chronic condition, we can observe that the person with having add-on mental health issues or a depression will have a significant poor functioning in his or her day-to-day life. Depression also increases the perception of poor health and utilization of healthcare services and the cost. Dementia is another major burden causing over a health system in general. So what is dementia? In short, it is a syndrome that usually of a chronic or progressive nature in which there is a deterioration of the memory. Not just memory, but also the thinking and behavior and ability to perform the everyday activities. So it's important to know that it's not normal aging. It's not a part of normal aging. This is a disorder. It can start at certain early ages also, rarely, but most oftenly After 60s or 65, we generally see the conditions, the symptoms, and the total number of people with the dementia is projected to increase up to 82 million by 2030 and around 152 million by 2050. So this is a huge burden over the overall healthcare system throughout the globe. Moreover, physical, emotional, and economic pressure that can cause great stress to the families and caregivers. It is really important aspects to know and to care about the psychological burdens of the caregivers of dementia people also, because there is a significant functional disability and impairment in this progressive disorder. We often see we often see the patients with delirium. Many of us know, must be aware of this condition as a ICU psychosis or acute brain failure condition, that is a delirium. The delirium is a condition, the underlying cause can be varied from the psychological or the mental health issues to the physical illnesses. It can cause, it is said that anything and everything under the sun can cause delirium. So to treat it, we need to find the cause and to treat the delirium. But most often we see that when it is a hyperactive delirium, it is very commonly noticed and frequently rapidly treated, rather than a hypoactive delirium, which is very commonly missed as a misdiagnosed as a case of depression or dementia. So we need to observe the proper symptoms. We need to observe the timeline of the symptoms, because the delirium is an acute condition. Dementia is a chronic and progressive condition. In delirium, we often observe the disorganized thinking. We often observe the fluctuating course of the mental status. Acute mental status changes are often common here. For example, the patient can have hallucinations, delusions, as well as the abnormal behavior, inattention. Psychomotor disturbances are common. It can be hyperactive as well as hypoactive, and acute disturbances in the cognition, attention, and orientation is primarily impaired in the cases of delirium. So, to diagnose the delirium and to know its causes for its treatment, that is, and to differentiate it from the delirium, dementia, as well as depression. That is a common problem while addressing the cases of delirium. Rarely we also see the cases of late onset psychosis or the late onset OCD in patients, in elderly patients, in elderly women. So we need to find out the causes. Most of the time, the underlying organicity needs to be ruled out while the cases we observe, because these are not the age of onset usually for this conditions. So proclinical neurological examination is important, but yes, the symptomatic management of the condition is also important. So we should be all aware of the symptomatology, even though the age group of the patient is different than the usual age of onset. So what can be done? So early diagnosis and proper implementation of the treatment and care strategies is the key for managing any mental health issues in the elderly women, in order to promote the early and optimal management. We need to optimize the physical and mental health and functional ability and well-being of the person. We need to identify and treat accompanying physical illness also, because that is significantly hampering the overall functionality of the patient. We need to detect and manage the challenging behavior and providing information and long-term support to the caregivers of the patient. That is a really important task while we are dealing with the elderly women. We need to assess if any of the elderly women in our home or in the society, in our vicinity, is suffering from certain risk factors that we can assess, and we can guide them to the proper healthcare facilities, including psychiatrist or a psychologist or a primary caregiver physicians, we need to check for the life tasks or the self-care activities if the person is able to perform or not. We can check for their safeties, including their financial safety, driving itself, etc. Whether the person is able to perform it properly or not. We need to observe physical health of the patient, whether it is deteriorating or it's certain different medical conditions are complicating the issues. We also need to check for the mood and the brain health, and finally the medication safety, whether the patient is taking regular medications or in proper doses or not. At large, when we are dealing with the or talking about the mental health care in the community setting, so we need to think of broader perspectives, like we need to train the health care providers, especially at the primary mental health care level, train them to psychoeducate them regarding the common mental illnesses, regarding their common symptoms and signs need to observe. And also we need to teach them to guide such kind of patients to a proper mental health care facility. It is equally important to focus on the long-term care of the older adults suffering from the mental health disorders, as well as to provide the caregivers with the education, training, and support. An appropriate supportive legislative environment based on the internationally accepted human rights standards is required to ensure the highest quality of services to the people with mental illness and their caregivers. There was a comprehensive mental health action plan that was designed by WHO, which mentioned the 4 key objectives: to strengthen effective leadership and governance for the mental health, provide comprehensive, integrated, and responsive mental health and social care services in the community-based settings, implement strategies for promotion and prevention in the mental health, and strengthening the information system, evidence, and research for mental health to improvise the mental health care in the community setting. Not in India, though, but yes, we do have certain healthcare promotional things that we need to practice in line to advance the mental health of the provide the proper care in the community care settings, like providing security and freedom to the elderly women, to provide them an adequate housing, to the supportive housing policies also, for especially for those women who are living alone in the house in the isolation. Social support for older people as well as their caregivers is also important. Health and social programs targeted at the vulnerable groups, especially those who are suffering from chronic or long-term physical as well as mental illnesses. Programs to prevent and deal with the elder abuse is really important here, and community development programs we can design. Gerontology social work is a growing field of practice and area of empirical research. So we need to highlight strengths of aging women, possess and explore the social and environmental factors that increases the well-being and quality of life. We need to understand the lived experiences and unique life transitions of aging women, understand how better provide appropriate and relevant mental health services to them. So just we need not to give them a sympathy that oh aapke saath kya hua hai, how can you live alone like this, how will you live life alone like this, all. No, we need to give them empathy, we need to treat them with the empathy, and we need to address their health issues equally as we are addressing the health issues, physical as well as mental health issues of the other age groups of the people. Psychoeducation of the family and caregivers is utmost important, along with giving them a proper environment and healthy environment for their joyful second inning of their lives, so that the elderly women can enjoy their life and their health to the fullest with our medical and psychological interventions. So thank you for your patient listening. And if there are any questions, they are always welcome. Thank you.
Thank you, Vikram sir, for your really empathetic and the guiding talk towards the need to consider the mental health issue of elderly women. Really, we should target on these factors, anxiety, depression, and dementia, and the focus should be that this is a normal part of aging. So thank you very much, sir. Over to Rishikesh Ghator, sir, for the next session. Thank you, everyone.
Thanks, Dr. Seema Sune madam and Dr. Vikram Wankhede sir, for such a nice talk and the great information we have gained from their talks. And thanks once again, Dr. Lakshmi Boy madam for chairing the session. So now we will be moving towards our next session. And for our next session, we will have Dr. Sarita Kadu madam, who is a developmental pediatrician and practicing in the Amravati since around last 25 to 30 years. And she had contributed to a great extent to our city and the society also. And she is running her early intervention society, early intervention center, and the school also in the Amravati city. And our today's topic, which will be discussed during this session, will be adolescent sexuality by Dr. Tuteja sir, and life during and after COVID by Dr. Nishikant Kotwal sir. So, Dr. Sarita Kodu, ma'am.
Thank you, Rishikesh Ghator. Today, it's my great pleasure to introduce our moderator, Dr. Satish Agrawal, who is the most enthusiastic and dynamic person. He is a MBBS and MD Pediatrics. He has done the DCH and DNB also in Pediatrics. He is a past president of IIP Amravati branch 2012. He is an EB member of Maharashtra IIP 2013-2016. He is an organizing secretary, Mahapedicon in 2005. It was a grand successful Mahapedicon. Organizing chairman of Mahapedicon in 2019 also. He is involved in the many social services by conducting TV shows, various health issues since last 6 years. He also writes the health-related articles in many local Marathi newspapers since last 25 years. He has received excellent award for his social awareness in 2018, received Sanpan Patra and got felicitated in Mahapedicon in 2021 for his social activities. Over to Dr. Satish Agrawal, sir. Please, sir.
Thank you, Dr. Sarita Kaur, ma'am. Thank you, Dr. Rishikesh Ghator. And thanks to all the speakers and chairperson in the previous sessions. It was all excellent. So it becomes my privilege to introduce today's speaker, Dr. Tuteja sir. Now, introduction on the part of Tuteja sir, he just say Dr. J.S. Tuteja from Indore is sufficient. So he is an iconic figure in adolescent medicine. I don't executive psyche, he has established the adolescent medicine in India. He is a creator and moderator of Adolescent India at the rate of googlegroup.com, a blog, which itself is an unofficial IP website where more than 35,000 pediatricians from India and abroad they log in. He was a national coordinator, Mission School Uday, 2021 from IIP, and a consultant counselor, teenagers issue, and a senior pediatrician from Indore. Dr. J.S. Tuteja sir, we welcome you to our CME and Pranam.
Thank you, Satish bhai. My video has been stopped by the organizer. The message I am getting.
So friends, without wasting my time, we straightway move to the topic, which is a very sensitive topic, that is adolescent sexuality. And it is supposed to be a talk which is very sensitive and sentimental, which nobody wants to talk in our family. The very word sex gives pleasure amongst our colleagues and friends, but when it becomes a talk between family members, especially with female members, then it becomes a taboo. And as per sir's advice, because we have been seeing all monologues, so let it be a dialogue. And sir has a lot to say, and audience will get benefited by sir. So I won't be talking much. And these are all the questions from audience only. Sir, the very first question, because we have all been listening about the physical health, mental health, and one of our friends asked, what is sexual health?
So can I start the talk?
Sure, sir.
Share screen, my.
Yes, sir, you can continue.
सर आपकी स्क्रीन अभी दिख रही है क्या? You are on the screen, sir.
सर आप शेयर कर रहे हैं?
हाँ मैं कर रहा हूँ सर.
इनको होस्ट बनाइए जी.
Already hosted, sir.
No. सर आ नहीं रहा है इसमें.
Presentation was visible, sir, quite time back. Initially it was visible.
शेयरिंग आ नहीं रहा सर.
लॉग आउट करके देखिए सर फिर से.
हाँ सर.